Hello everyone. As you heard, my name is Előd-Zsigmond and my PhD topic is about the management of cardiac implantable electronic devices. My vision is that we have to learn from each other, and this way we can create a brighter future, and my mission is to do so in the miscellaneous group. So up to now I have two ongoing projects which I will present in details. In the first one, we are investigating the effect of different optimization techniques in patients with CRT, with cardiac resynchronization therapy in the context of a systematic review and network meta-analysis. So we know that CRT is the gold standard treatment of heart failure patients who have long QRS durations, wide QRS and left bundle branch block morphology. But unfortunately, up to 40% of CRT receivers are non-responders to a therapy, and these patients also have poor long-term outcomes. Now, some studies suggested that in these so-called non-responders, atrioventricular and interventricular asynchrony is really prevalent, and we also have studies which stated that we have an acute improvement in patients who are optimized. So if we optimize our devices, these intervals, we can improve CRT response rate. The problem is that we have many different techniques to optimize our devices. The gold standard technique of device optimization is considered echocardiography, but the problem with this technique is that it is really subjective and burdensome. So automatic algorithms were developed, static and dynamic algorithms, and we also have an option to not optimize anything and let the patient just be. So the aim of our study was to find the best optimization technique to improve CRT response rate and long-term outcomes, and we did this with a special focus on dynamic algorithms. We conducted our systematic search in 3 databases, and we found 43 eligible articles which reported the outcomes we wanted to analyze. And the first outcome pack is echocardiographic outcomes, echo response, which is a dichotomous outcome, and also improvement in left ventricular ejection fraction and decrease in end systolic volume and end diastolic volume. These forest plots are a little bit different from other forest plots. So here you can see individual studies, but the comparison arms, the all network estimate for each comparison, echo, empiric device settings, and static algorithms compared to dynamic algorithms. And as you can see, we found that the odds of echocardiographic response, the mean odds, were 2 times higher in case of dynamic optimization, and this also reached statistical significance if we compared it to echocardiography. Unfortunately, you can see also dashed line confidence intervals, which means that this comparison was not done in the real life. We have only a network estimate, an indirect comparison, and here we had no data about static algorithms. In case of continuous outcomes, none of the comparisons reach statistical significance, but you may have noticed that there is a clear trend that with dynamic algorithms we may achieve better outcomes, but again, this was not statistically significant. But this trend, it is really nicely visible on these supraplots, where the treatments are ranked basically by the probability of achieving better outcomes, and the red line representing dynamic optimization is pretty high in every comparison, in every outcome. We also analyzed clinical improvement, all-cause mortality, heart failure hospitalization, clinical response, and 6-minute walk test, and the follow-up duration for these outcomes was 3 to 12 months. In case of all-cause mortality, we didn't observe relevant differences. However, in case of heart failure hospitalization, again, in the comparison with echo versus dynamic optimization, we observed a significantly lower event rate in the dynamic arm, and clinical response also showed a strong non-significant trend favoring the dynamic group. A 6-minute walk test is also a measure of clinical performance, and this was significantly better in case of dynamic optimization. We were also interested in the scenario where we have chronically implanted CRT patients who are considered non-responders to the therapy. And in this case, we found 7 studies, but the studies used really different response criteria, really different optimization methods and follow-up time. So we just did basically a review, a summary. But we can observe that up to 70%, but at least 30% of the patients can be improved if we use some kind of optimization, which is really remarkable. So in conclusion, we can say that at the time of the implantation, instead of echocardiography, we should use dynamic algorithms. And we also can state that optimization should always be considered in case of non-responders, because we see that these patients, at least some proportion of these patients, are improving. The problem with our study is that we can't answer the main question of optimization. We can't answer if dynamic algorithms are better than empirical device settings. So we definitely need more trials in this area. Here you can see the first version of our graphical abstract. Now we are correcting the manuscript based on the comments of the internal review. And here you can see our deadlines and our target journals. And just shortly about our second project. In this study, we want to investigate the role of biomarkers in predicting device infection, and we want to investigate this in a registry analysis. So the problem with device infection is that although it has a relatively low incidence rate, the mortality rate is really high, and if we want to treat it, we have to extract the total endovascular system and combine this with antibiotics. So it is really important to prevent this complication. And in the guidelines, we find some recommendation for the prevention of device infection. So we know that if the patient is presenting with clinical signs of infection, for example with fever, we should delay the implantation. But what if the patient has some subclinical infection and we don't really see clear clinical signs? In those cases, we have hematological parameters, biological markers like PCT. But a recent meta-analysis stated that really few data are available about the correlation between hematological parameters and CAD infection. So in our analysis, we want to investigate if these biomarkers can indeed predict early and one-year device-related infection. Here is an overview of our projects, and I would like to thank you for your attention.
Thank you, Előd. Any questions?
So I think that it's very, very important regarding your optimization data. So there's no point trying, you gotta go for that. So some kind of optimization is not enough. I think that this can be one of the reasons of being non-responder after the CRT implementation, because not proper optimization means death, because there's a definite relationship between mortality and optimization. So congratulations, but this is only the first step, right? Because are you planning to analyze your own data of the hospital? Are you just saying, or you're reading it?
Yes, I definitely want. The only problem is that this has to be some prospective analysis, so we have to wait. But we will have the results of the adult response trial soon. This trial investigated a dynamic algorithm ACRT versus standard of care, I think. And there we see some clue that optimization may be good, and also the battery life of the devices is more beneficial, is longer with this algorithm. But we are waiting for this article. And in case of analyzing our own data, I think it is really important also to see how these algorithms are working in real-world settings, not just in RCTs.
I mean, analyzing your retrospective data, that's your work, I guess, because you will have like hundreds and hundreds of patients living with CRTs, and I'm aware that like 10 years ago, we used like different settings and different evaluation methods than nowadays. There's point analyzing our current patients as well.
I have a question, Előd, to your second project. And that is a $1 million question, right? I mean, you perform an intervention, an invasive intervention, an operation, and you want to predict if there's going to be infection in 1 month and 1 year. I mean, is it really feasible? Because this approach could be used in any type of surgery. So, and then it makes me think that, I mean, I'm sure there were efforts, or there have been efforts in order to do that. But it's, so you really think it's feasible to find a biomarker combination or anything that can predict infection?
Thank you for the question. So our aim with this study, the first aim is to find some biomarkers. And if we don't find it, our second aim is to prove that, okay, if you see someone with elevated CRP but no clinical signs, you should not delay the implantation because you see that there is no infection.
Very good point. Excellent. Yeah.
Do you routinely do that?
Sorry?
Do you routinely do that?
I don't do implantations, but we... Yes, and we are routinely, so we want to analyze those biomarkers which we are routinely analyzing, receiving for our patients.